This is a high-density briefing on the 18 core recommendations from the 2026 Korean Society for Vascular Surgery Clinical Practice Guidelines for Abdominal Aortic Aneurysm Management. We will focus directly on the practice-changing updates and the evidence base supporting them. We'll proceed through 5 key areas, following the clinical workflow. First, the core indications for intervention. Second, the decision matrix for EVAR versus open repair. Third, management of high-acuity presentations like rupture and infection. Fourth, post-repair surveillance and complication management. And finally, we'll conclude with key intraoperative technical considerations.
Let's begin with Section 1, Core Surgical Indications.
The fundamental clinical decision in elective AAA management remains balancing the inherent risk of rupture against the operative mortality. The following recommendations define the current evidence-based thresholds for intervention.
Okay, looking at the table, Recommendation 1 gives a conditional go-ahead for repair of fusiform aneurysms at the 5.0 to 5.5 centimeter mark, and this is based on high-quality evidence. Recommendation 2 suggests we consider early repair for saccular morphology, though note the low-quality evidence base. Now, the most critical point here is Recommendation 3. It's the only strong recommendation in the entire guideline. Do not perform emergency surgery for symptomatic, non-ruptured aneurysms. The rationale for surveillance of smaller fusiform aneurysms is grounded in high-level evidence from 4 pivotal randomized controlled trials: the UK Small Aneurysm Trial, ATOM Pivotal, and CAESAR. When you look at the pooled data from these trials, it's clear there is no survival benefit from early repair of AAA smaller than 5.5 centimeters.
And the guideline is absolutely explicit on this point. It states, emergency surgery is not recommended for individuals with AAAs who present with abdominal, back, or radiating pain in the absence of definitive evidence of rupture. This strong recommendation really marks a significant shift in practice, moving us toward a deferred, urgent repair under optimized, elective conditions to improve outcomes. And the data supporting that strong recommendation is unequivocal. This meta-analysis of observational studies demonstrates the significant mortality penalty associated with emergent repair for these symptomatic but non-ruptured aneurysms, compared to elective or even semi-elective procedures.
Moving to Section 2, Treatment Modality. This is the core decision point: EVAR versus open surgical repair, or OSR.
Recommendation 4 gives a conditional preference for EVAR over OSR in patients who are anatomically suitable. However, this decision is heavily nuanced by a critical trade-off between short-term benefits and long-term durability. The short-term data, which comes primarily from the landmark EVAR-1 and DREAM trials, is very clear. It demonstrates a distinct 30-day survival advantage for EVAR.
But that early survival benefit does not persist. As you can see from the long-term follow-up data, all-cause mortality rates converge and become statistically equivalent by 8 years post-procedure.
And this brings us to the central trade-off. That early mortality benefit you get with EVAR is offset by significantly higher rates of long-term reintervention when you compare it to the proven durability of open surgical repair. So this leads directly to Recommendation 5, which specifically addresses the younger patient cohort. For patients under 70 with a life expectancy greater than 10 years, OSR should be seriously considered. This reflects the real-world concerns about the long-term durability of EVAR, even though meta-analyses might show an equivalent 10-year survival. Next, Section 3, where we'll cover the management of complex presentations, specifically ruptured and infective AAAs. For ruptured AAA, the guideline outlines a very clear 2-step protocol. Step 1 is resuscitation, where Recommendation 18 conditionally supports permissive hypotension. We're talking a target systolic blood pressure of 70 to 140 millimeters of mercury before you achieve proximal control. Then Step 2 is repair, where Recommendation 6 conditionally favors EVAR over OSR when it's anatomically feasible. This stance is well supported by evidence from the IMPROVE trial. Now, for infective IAs, there's a quick point on terminology. The guidelines advocate for the precise term infective native aortic aneurysm. This replaces the older, misleading term mycotic aneurysm, which, as we know, incorrectly implies an exclusively fungal cause. According to Recommendation 7, EVAR can be considered. The supporting meta-analysis data you see here is quite compelling. For infective AAA, it demonstrates a significant reduction in 1-year mortality with EVAR, making it a very considerable option for these high-risk patients when it's both anatomically and clinically feasible.
Let's turn to Section 4,
post-repair management, which covers both surveillance protocols and the specific triggers for reintervention.
For postoperative imaging, recommendations 8 and 10 represent a major shift away from rigid, one-size-fits-all protocols. For both EVAR and OSR, the guidelines now advocate for selective, tailored imaging based on individual patient risk, their clinical status, and the surgeon's own experience.
The guidelines also provide a very clear algorithm for managing post-EVAR endoleaks. Per recommendation 12, any type 1 or type 3 endoleak warrants consideration for re-intervention. Now for type 2 endoleaks, recommendation 13 is very specific. Only consider treatment if it's associated with an aneurysm sac enlargement of 10 millimeters or more. And finally, recommendation 14 addresses endotension, advising re-intervention for any continuous sac enlargement even if you can't detect an endoleak.
Finally, let's cover the fifth and final section, intraoperative technical considerations. We have 3 final recommendations that address key technical decision points. Recommendation 15 advises preserving at least one internal iliac artery to mitigate the risk of buttock claudication. Recommendation 16 advises against routine IMA reimplantation, pushing instead for a more selective approach based on perfusion. And finally, Recommendation 17 leaves the surgical approach for complex anatomy, like an inflammatory AAA or a horseshoe kidney, to surgeon discretion based on patient-specific factors.
So to summarize, these guidelines provide a clear, evidence-based framework for AAA management. The central challenge for us as clinicians remains applying these guidelines to our individual patients. This is especially true for the decision between EVAR and OSR in younger patients with a long life expectancy. That trade-off between short-term mortality benefit and long-term durability continues to be a key area that requires nuanced clinical judgment.